Okay, let's just jump in. Right, folks, here we go. Another episode. Welcome back and all that. Bit of a weird one this, because I'm doing this in person, and I've not done an interview in person before. I have done an interview in person before, but it's been about 2 years since I last did it. Because you all know I'm a bit of a social rattlesnake, a bit of an unsociable bastard. So I like to do this stuff like via Google Hangouts. But today's guest I actually know personally. So, okay, let's jump in. So my guest today is
a bit anxious.
My guest today is Dr. Sara Tai. She is a senior lecturer in clinical psychology at the University of Manchester and a consultant clinical psychologist whose research focuses on the science and practice of psychological interventions, including cognitive theory and perceptual control theory. She is the co-author of a number of books, including a transdiagnostic approach to CBT using method of levels therapy. That's the one I always harp on about, method of levels. If you want to learn about it, get that book. That's the best book. And she is currently involved in clinical trials and experimental research, developing psychological interventions for psychosis and bipolar disorders in Texas, Philadelphia, Illinois, Beijing, Europe, and the UK. Sara, welcome to the podcast.
Thank you
for joining me. Before we jump in, I've said this before about academics, but it seems like you guys live the life of rock stars. Just always sort of jetting off around the world, different countries. And I know it's not going to be like, it's not like you've got a tour bus and a sort of a Byzantine fruit bowl full of cocaine or anything like that. But there's a lot of jet setting going on. I see the clinical psychologists on Twitter are always like, oh, I've gone to a convention that always just so happens to be somewhere with like crystal clear ocean waters and white sandy beaches. And so I'm going to ask you now whether is that just an illusion for the observer, or is it a bit like, is there a bit of glamour to being an academic?
Well, I think you're right in that there is an awful lot of travelling, and I've been doing a lot recently because we're running a trial in psilocybin, actually, which is magic mushrooms in mental health, and we're running that across North America, Canada, and Europe. So I've been travelling all over there. And I think my worst case scenario recently has been getting on a plane, going to Toronto, flying back overnight into work, and then getting back on a plane and going back to the States. That was probably the worst. But the reality of it is far from glamour. It's actually seeing the inside of an airport, a plane, and then the office where you're working, and then going back. So you don't get to see anywhere that you are. It's totally unglamorous, I'm afraid.
Right, okay. But when I said it's jetting around the world and there's no drugs involved or anything, in your case, there are drugs involved.
There's a lot of jet setting and many drugs.
Right, okay. So today we're going to talk about sort of how to live with bipolar disorder, like what to do about it. So back in, all the way back, episode 14, I did an interview with, I should have jotted this down considering I've got my laptop in front of me, Professor Stephen Jones.
Oh yes, I know Steve very well.
Yes, up at, is it Lancaster University? Yes.
At the Spectrum Centre.
That's the one.
That's an excellent work going on there.
So I interviewed him, and it was sort of a basic introduction to bipolar disorder. And then afterwards, a lot of people were like, people that have been diagnosed with it or think that they've got bipolar, or however you want to conceptualize it, sort of emailed after like, great introduction, what the hell do I do about it? And so for those people, it's only taken me like 2.5 years, but we finally got around to maybe confronting this. So that's what I want to talk about today. And this discussion's based on it's a paper that you co-authored. I think it's Living the Life You Want Following a Diagnosis of Bipolar Disorder. Credit to Helen Warwick.
Yes, so Helen Warwick was doing that research while she was doing her training as a clinical psychologist, and both myself and Warren Mansell supervised her doing that. And the basic idea was to really ask people who regarded themselves as having recovered from bipolar disorder what it was that had enabled them to do so and what that meant to them, what recovery really meant from their perspective.
Right. Okay. So I'll just read this quick paragraph out, because this is just going to be like a brief summary of what we're going to sort of cover today. So this is from the abstract. It said the analysis revealed 10 overarching categories of what participants reported to be important in their recovery: support, recognition of the problem, believing that things can change and not giving up, instinctive curiosity, medication, psychological therapy, becoming the director of your own life, changing how I think, accepting who I am and how I feel, and looking after me. And so we're not going to go through it at sort of all 10 points. There's things that sort of stand out more than others to me. But even though I've said go back and listen to episode 14, I know most of you aren't going to bother. So let's start with a sort of a brief introduction to what bipolar disorder is. And so, yeah, I guess I'll throw this over to you. If you give us sort of a brief description of what it is, and then we'll pass that out a little bit.
Yeah, absolutely. So again, bipolar disorder is a label that we use to describe people who have a whole broad range of symptoms and experiences. But it's most commonly known to be periods of intense depression and then periods of what is not the opposite of depression. So it's not as though you're feeling happy, but you're more elated. Your mood is brittle. It's a little bit expansive. People feel quite irritable. So it's the opposite of depression in terms of how it appears, but underneath that, they're not really so different. So people's moods are swinging to and fro from feeling very low and, inactive to really being quite high and brittle and irritable and much more active. And of course, there's mania, which is the extreme of those experiences, and also hypomania, which is the same kind of experiences, but to a lesser degree, lesser intensity, lesser frequency and duration. So people who have a diagnosis of bipolar disorder experience the extremes of those moods. And if we look at those experiences as existing on a continuum, it's not always that you go from one to the other. People experience the whole array of mood experiences along that continuum. And it's the change in moods that happen quite suddenly for people which are disruptive. Or it's the going from one extreme to another, which makes it difficult for them to predict how they're going to be able to manage or what they'll be able to do on one day, because they really don't know how they're going to feel.
You see, on the face of it, you could take that description and think, well, that's the sort of experience of being human. Everybody experiences extreme emotions. Everyone feels like total shit sometimes, and then everyone gets like maybe a bit giddy or hyper or whatever at other times. So why would it be fair to sort of classify this as a distinct phenomenon?
Well, as you know, I'm not somebody who particularly agrees with the whole system of diagnosis and classifying things as disorders. But what I wouldn't want to do in saying that is make out that there are some people who don't have a problem, whose difficulties don't interfere with their life to such an extent that it doesn't cause them huge amounts of distress. So I guess the people who end up receiving a diagnosis are the ones where their difficulties with mood swings are to the degree where they're no longer able to do the things in life that they need to do to function and live the life that they want.
Yeah, I guess I think another reason people get diagnosed with this disorder isn't necessarily just based on their sort of levels of distress of it, but it's based on whether or not other people think their behaviour is inappropriate.
Yeah, and that's all part of to what degree are they functioning. So people who usually end up in hospital or who receive a diagnosis, for example, when they're low and depressed, it's really difficult to even get out of bed. You can't even sometimes feed yourself properly, get dressed, do the things you need to keep yourself safe and, to have any form of positive well-being. When you're high, it might be that your behaviour is so extreme that you've really lost the ability to monitor and understand what you're doing. So some people do things that cause themselves huge embarrassment at a later point. They may go and have random sex with someone that they wouldn't have normally chosen to do. They may well go and spend huge amounts of money and later be in such debt, and that's had such a negative impact on them and their families, they have huge amounts of regret and sadness over what's happened. So we're not talking just your average extreme mood swings. We're talking to such an extent that your behaviour is very different to how it might be usually.
Yeah, so I'd say the sort of the big, one of the big arguments going on in psychology, psychiatry at the moment is this, what are the origins of distress? Is it a chemical imbalance, quote unquote, or is it are these sort of reactions to some sort of trauma, life circumstances or whatever? Now, I'm more in favour of the idea of these being responses to some sort of trauma, life circumstances, etc. But the thing about bipolar disorder, and I think the way a lot of people conceptualise it, particularly people that have been diagnosed with it, is there is something chemical going on. It seems to lend itself to a chemical imbalance theory. The idea that it's tricky to see why, say, someone would go out and spend a lot of money or be promiscuous in response to difficult life circumstances, and maybe more that just every now and again there's a switch that's flicked chemically that changes the behaviour. And so if you could just sort of deal with both of them, whether there's evidence that there's something chemical going on with bipolar disorder, and then if it's not that, how do we explain it as a reaction to life circumstances?
Yeah, sure. Well, for those of you who are listening, Danny and I were having a conversation before this about chemical imbalances, so I've totally rubbished that one. And as you know, there is really no evidence for there being any abnormal levels of chemicals in the brain. There's just not evidence to support that. But what I'm not saying is that biology is not a part of what's going on. And so what we do know is for people, for example, when they've maybe had a long journey flying eastwards, or in the winter when there's less light, that does have some biological implications. It has an effect on how you feel physically. Light does. There's no doubt that there are things that happen in the environment that can impact on what's going on physiologically. But to say that bipolar disorder is primarily a biological problem and that there are things that cause it is equally just not very accurate. So we can't look at problems being down to having one cause. There's a whole number of things that are going on that interact. So for somebody who has received a diagnosis of bipolar, let's just use an example. That person may well naturally, temperamentally, be a little bit more prone to having mood swings than somebody else. That doesn't make them abnormal. That just means that naturally they have slightly different mood swings. But they may well have grown up in a family where culturally, to show that you ever feel low isn't acceptable. Nobody wants to see somebody who's depressed. You've got to be up all the time. You've got to be happy. If you're not feeling on top of the world, you're dull. We don't want somebody who's miserable in front of us. Come on, pick yourself up. And that kind of culture may well lead to somebody using strategies to manage their mood that naturally pushes their mood up even further. So if you're someone who believes that other people won't want to be around you when you're low, you're going to start to use strategies that try and increase how you feel. I'm going to try and put on a brave face. I'll push myself, really egg myself on and try and force myself to feel better. So there will be both psychological and behavioural strategies that you use to manage your mood that may naturally increase it further. Then, if you are in life circumstances where perhaps things aren't feeling that great, things are very stressful, and again, your way of coping is to push your mood up, we're starting to see that there are lots of reasons here for why mood might shift even more. Many of the people that I've worked with who do experience very extreme highs in their mood start to talk about all of these strategies that they use on a regular basis. if now we were to bang on some loud music, really try and pump ourselves up, maybe start going out, let's start drinking more, having less sleep. So the less sleep is interesting as well, because the less sleep you have at first, you do start to feel slightly hypomanic and a bit pushed up, don't you? I mean, I certainly do. And
I appreciate that, yeah.
I quite enjoy that feeling occasionally when I haven't really had a great night's sleep and I feel a bit more hyper and a bit more alert and everything's a bit brighter and a bit more exciting. But then if it goes on for too long, I'm more irritable and it doesn't feel good. And this is, again, what we're seeing is something which is very normal, but nonetheless that lower end of what many of us regard as, a little bit hypomanic. Now, if you start to make that go on for a while longer, those symptoms perhaps get a bit more acute and a bit more less controllable. The longer it goes on, and by this point maybe you're drinking more, maybe you're starting to socialise more, your mood's being pushed up and up, you start to lose control a little bit over monitoring your own actions, about what you're saying. Maybe we start to be a little bit more inappropriate, and before you know it, it's moving into the realms of really problematic. So what I'm saying is the mechanisms by which mood starts to swing are quite understandable. And if you're not doing anything about that and you're maybe taking drugs or doing other things that's going to push it into the extreme, it's easy to lose control.
Yeah, one thing I'm wondering is whether you think bipolar disorder is sort of overdiagnosed, in the sense that I've met plenty of people who've been diagnosed with bipolar disorder based on sometimes on a single incident of inappropriate behaviour, which seems to be an accusation that gets thrown at women more than it does men, interestingly. And people getting this diagnosis based on the fact that they have mood swings, and then all the way up to people having this diagnosis because they have experienced it at a more sort of to an extreme degree, where it's not just sort of depression and mania, but it's people that are suicidal on one hand, and then maybe have been committed a crime or been violent on the other hand. And yes, it seems to me that I would guess that it's overdiagnosed. I understand it as being classed as a serious mental illness alongside the likes of schizophrenia, psychosis. But I'm just wondering what you think about that, whether it's the fact that it exists as a sort of on a spectrum as a matter of degrees, whether that's a reason that it is overdiagnosed, and that maybe it should just only be for people who experience it at the more extreme ends.
It's a difficult question to answer, because you're asking me about something that I sort of fundamentally don't even agree with. Right. So the concept of diagnosis, I just believe that diagnosis has been used to describe experiences that are very variable, but diagnosis has been used in a way where those experiences become concrete entities, as though they are set things that really exist. And that, I don't believe, is the case. I think, as we've been saying, there's a whole realm of different experiences, and we've portioned off the most extreme of those and started to call them a diagnosis of bipolar disorder. I'm not denying that people who have some of these experiences at the extreme end are not happy, their lives are being ruined by it, and it's a real problem for them, and it's very distressing. But whether that means there's this real entity called bipolar disorder that has some underlying biological cause, I'm struggling with that one.
Right. And so, as far, you see, one of the things that I wanted to sort of confront with this conversation was there are plenty of people out there that have either got this diagnosis or have diagnosed themselves and don't trust to hand themselves over to a therapist, to the system, to a psychiatrist or whatever, and they want to sort of help themselves. But as part of that self-help approach, I think a lot of people will diagnose themselves with bipolar disorder. And it seems that, you know, to self-diagnose with depression seems it's sort of acceptable.
Yeah.
You know, there's a chronic sadness and all the symptoms are there, and it's like, okay, well, I'm depressed, and it seems legitimate. And the same with anxiety, and maybe the same with something like with that, agoraphobia, where you're not leaving your house. It's pretty simple to pin that label on there. But I'm wondering about if we're going to use the conceptualization of diagnosis just as a descriptor of a certain set of phenomena, observable phenomena or subjective, whether it's legitimate for people to diagnose themselves with bipolar, or is that something that really should be done professionally?
Well, the criteria for bipolar disorder over the years has changed anyway. So if you go back to the 1980s and then compare it to now, you'll see quite a shift in what's even been classed as, what the diagnostic criteria are. Now, years ago, and I'm talking probably before the era of, antipsychotics and lithium, for example, the true incidence of people experiencing what would be classed as mania was quite rare. It's probably about 1 in 5,000, I think. And nowadays, people who are getting a diagnosis of bipolar disorder is 1 in 50. That's a massive change. And some of that is about the diagnostic criteria having changed, but some of that's also about people self-diagnosing, and anything that involves a mood swing is now being labelled as bipolar disorder. Now, whether that's helpful, I think, is really down to the individual. There are some people where having a label to identify their problems and sort of being able to seek help is really useful. But for many others, it's the worst thing that's happened to them. And so I would hate to say, oh no, if you are having these sort of mood swings, diagnose yourself and you've got bipolar and you need to seek services. Because what people need in terms of recovery, and this is what our research has shown as well, is vastly different. So we need to help people recognize when they're distressed, when the things that they're experiencing means that their life is not the way they want it to be, and allow people to choose for themselves whether or not they need help and what that help should be.
Well, that sort of brings us nicely into tackling some of these categories that were identified in this review, and one of them is a recognition of the problem, and as part of that is a diagnosis. The thing that's interesting to me is, when you say that for some people a diagnosis is helpful and for some people it isn't, for some people it's it make things worse, is there any way of preempting that?
Well, I think the people where they found diagnosis has been helpful is it was just recognising that what was going on in their life was a problem. Because quite many people say they sort of bumble along and they're getting into trouble, or relationships are breaking down, or they're not doing very well in their job, and they're sort of self-blaming because of that. And then when they realise, there's a label that explains what's happening here, there is a problem here, it's not so much the diagnosis itself that they found useful, it was simply the recognition that something wasn't right.
Yeah.
And in our interviews, what many of the people who've lived and been through this were saying was that was just step one, was recognising that there was a problem. And the diagnosis bit, where that was helpful for people, was just in that it allowed them to go and seek help from somewhere. And for others, the real sort of golden nugget in making a difference was realising what it was in their life that wasn't the way they needed it to be. So they worked on that as a way of helping things feel better, rather than just receiving the diagnosis in and of itself, if that makes sense.
Yeah. What about for the people that say that a diagnosis was unhelpful or damaging? Why was that the case for those people?
Yeah, the people who talked about it being damaging were those where they got a diagnosis, they got into services, and the help that they received in services didn't really meet their needs. And I think this happens to a lot of people. I regard any mental health problem as being predominantly the result of something in your life not being right. It might be that a relationship's wrong. It might be the way you feel about yourself. It might be that you haven't realised your potential in the way in which you want. There's a whole number of different things. It isn't you have an illness and therefore that illness needs treating. The illness or the symptoms or the diagnosis is the consequence of whatever it isn't right in your life. Now, if you enter services and the focus becomes all about the diagnosis and the symptoms, all your attention is consumed by that, and you may never get to realise what it is in your life that's actually the problem.
Right.
So if that goes, carries on and you never deal with it, and your focus is all about the symptoms and the disorder, you become this sort of career-long patient where the help that you receive never really brings you closer to making your life the way you want it to be. And that's what people tell us is the problem.
Right.
They get sucked into maybe years of medication, years of having other types of treatment that never really arrive at the real problem, which is in their life.
Well, interesting segue. So we've talked about how your conceptualization of it, your understanding of it is that, there's no evidence for this idea of a chemical imbalance going on. But then one of the categories that was raised here is medication. So how do we square that circle?
Well, that's fine, and it totally fits, because I wouldn't want people to hear what I'm saying is biology doesn't have a role and medication can't be helpful, because I'm not saying that. What I'm saying is medication actually can be hugely beneficial. If you've got to that point, as I was speaking about earlier, where you're feeling so out of control, you no longer are monitoring what you're doing, you're drinking, you're going out, you're not sleeping well. Things are way beyond a point where you can really harness what's going on and get things back to baseline. So medication in those instances may well be enough to just bring somebody back down to a sort of happy medium, enough to then start doing some work on what they need to focus on. So I think medication can be enormously helpful, but as a long-term option, I think it may potentially stand in the way of people really getting in touch with their feelings and understanding what might be wrong in their life. So I'm saying it's not the route to, a happy life in and of itself. And that's certainly what many of the people that we interviewed were telling us.
Yeah, this sort of raises the question about the disease-centered model of medication versus the drug-centered model. So this is Joanna Moncrief's idea. And yeah, for anyone that doesn't know, so the disease-centered model would argue that the medication is sort of addressing the problem at a chemical level and fixing it, whereas the drug-centered model, Joanna Moncrief's idea, is that the drugs are having an effect because you put chemicals in your body, it has an effect, but it's not actually addressing the disease, quote unquote, directly. It's a little bit
itself. Like you have a disease. So, for example, an infection. You take antibiotics. Those antibiotics are directly targeting the infection. Yep. Whereas in psychiatry, that's not the case. The drugs have not been developed specifically for a disorder which probably doesn't even truly exist. The drugs are, though, creating some biological change. And for some people, that change may be helpful, but it's not going to fix the problem.
So, what are those drugs primarily doing? If they're not addressing an underlying chemical imbalance or some biological malady, then
they're creating a chemical imbalance. Actually,
right? They're
not correcting one; they're creating one.
But in what ways is the chemical imbalance that they're creating favourable? Is it more like, is it about bringing the mood of depressed people up, or bringing the mania down? Is it numbing people? In what way is it helpful?
Well, for some people, it may improve their mood or bring their mood down. I mean, if you and I sit here and for the next few hours we eat a ton of sweets, so the sugar we've had goes up, we're going to feel quite different, aren't we? Mm-hmm. It doesn't mean that those sweets has corrected a sugar imbalance, far from it, but it's created a change in us. And we may even feel some benefit. We might have quite a nice time,
right?
Feel a bit giddy, feel a bit happier. Yeah, wonderful. But it hasn't changed a problem.
Right.
And it's the same with a lot of the psychiatric drugs. Many of them may well lift mood enough to help people get through a very difficult time, or to be back into a place where they can think about what's going on and sort things out. Lithium, for example, is very effective for some people in preventing those huge mood swings.
Right.
But it's not creating a change that's addressing some biological deficit or problem.
Right.
You know, it's creating a change that for some people, and I stress some, usually, the sort of law of effect when it comes to psychiatric medication is that it'll benefit about a third of people. It won't make much change for a third of people, and a third of people might even get worse.
Right.
So it's not even affecting everybody in the same way and having the same effect.
Right. Okay. I'm wondering, it's not quite a flip of a coin, that one, is it? It's I'm just wondering whether do you make recommendations to people to whether or not to give it a try?
Yeah, I mean, I like I said, I'm not anti-medication. I'm anti-misinformation.
Right.
And telling people that they work in ways that they don't. And also I'm anti people not having a choice. I don't like the idea of telling people that a medication is going to correct this specific mechanism and will work for them. I think we get people's hopes up, their expectations up, and it also gives a message that the answer is in changing some biological thing, where rather than saying, look, there are other things going on that you have a role in changing. You know, you have some ownership here of other things that you might be able to do as well.
Right.
And don't hear that as me saying, I think that people have mental health problems because it's their fault. I don't. But I do think there are things that people can do to help themselves.
Right. Okay. So again, nice little segue. So, taking medication, you're not addressing the problems, the life circumstances, underlying issues that are maybe causing this in the first place. So that brings us to another aspect that was mentioned, and that's psychological therapy. Now, over the course of doing this podcast, I've sort of become ambivalent towards therapy. And I'm back to not knowing where I stand on it. With the evidence is all over the place, that people's access to it, people's experiences with it, and again, there's a lot of people out there that I hear from that tell me to do self-help episodes. Give us an episode that tell me what to do, because I don't want to either. There's no point in trying to access services, like the waiting lists, like in the UK, are too long. Or I don't trust people. I don't like handing myself over to somebody else for them to try and fix me. And I sympathise with that perspective. But when it comes to something like this, which is considered, it's in that bracket of serious mental illness, what would your response to that be, as far as recommendations to somebody, especially people that are reluctant to go that route?
Well, I've already said that I truly believe, and I'll hold my hands up, and I am very influenced by perceptual control theory, where the idea is any form of mental health problem comes about because there is something in your life that's not the way you want it to be. You don't have control over the important things that you need to have some control over. And usually the reason that happens is because the things that are important to you may not fit together very easily. So, for example, it's really important for me to be successful in my work, but it's also important for me to be a good parent. Doing both of those at the same time, balancing those, isn't always very easy. So when I'm not balancing those very well, I'm going to be more distressed. I'm not going to feel as though things are the way I need them to be in my life. Now, quite often, I mean, that's a very mundane, everyday example that we can all relate to. But for people with more serious mental health problems, the kind of things that are not being balanced, the things that aren't right in their life, can feel pretty severe. And they've also been chronic. So we're talking a long time of not being able to balance and have control over the things that are important to you. And so that level of distress is enormous. But people are often not aware of what those things that they need in their life are, or they're aware of one of them but not the others. Going to therapy And where I think therapy is helpful is that it helps people become aware of those things and then start to figure out new and novel solutions to finding ways to balance those important goals. Now, unfortunately, there are a lot of therapies out there. In fact, at last count, it was over 1,000.
Mm-hmm.
And they all have their own unique model and way of doing things, and they all have their own formula of what somebody needs to do. But I've already said what the real answer is people figuring it out for themselves and finding out what those important goals are and how to find a novel solution. You can't do that for someone. Somebody has to figure it out for themselves. And therapy that helps somebody do that is good therapy. Therapy that gives people advice or a magic formula probably isn't going to be so helpful, because it's unlikely that that advice will be tailored for that individual, or maybe not even very helpful at all. So in our research, we've said that therapy that is effective is one that helps a person focus on the true problem at hand for long enough for them to start to develop awareness of their important life goals. And to do that, when you're talking about your problem in therapy, you have to get that emotional, felt sense of it. It's got to feel real. You're not sitting there intellectualizing or, just waffling on, giving it the yeah. You've really got to get a felt sense of what that is. And so your awareness of what you need increases, and figuring out a solution, this way of balancing these needs, is really a trial and error process. The time it takes is different for each individual. For some people, they may have one therapy session and, they get that light bulb moment. For others, it might be 30, 40 sessions over a year or so. It's like learning a language. It takes different people different amounts of time. And the first solution that you arrive at might not be the one that works best for you. You might need to try a whole number. So if you're going into therapy that's really rigid and telling you what to do, the chances of you being able to go through that process and figure it out for yourself, it's just less likely.
Do you think that the chance of somebody figuring out what these underlying problems are, of why they feel like they've lost control in their life, is that more likely to be facilitated by sitting down with a therapist than trying to do it yourself?
Well, what people are really needing to figure out is what is it they want in life. So not just what isn't right, because something is only not right if it's blocking you from getting what you want. So the real answer is figuring out what it is you need and how to go about getting that. Now, if you're sitting there all day, ruminating in your head, so if I said to you, think about something negative that's happened to you recently, come up with one sentence in your head as to what that means about you, and repeat that sentence silently in your head over and over and over, it's not going to feel very good, because I've successfully got you ruminating.
I'm doing it now.
Yeah. Not feeling too good, is it?
No.
No. Whereas if I said to you, say that out loud, that sentence, for most people to say that out loud doesn't feel as though something is something they want to do. They're scared to do it. But once you've done it, quite often people feel that saying it out loud, it takes on a difference qualitatively.
Yeah, it does.
Somehow, that shameful thing that you thought it was going to sound like, it's not so bad now you've said it out loud. And the response that the person you say it to might not be what you expected. So automatically, by saying it out loud, you've started to look at it from a slightly different perspective.
Right.
And that's what therapy is about. It's really enabling you to express something externally, because that makes it different. It makes it sound different. It makes you evaluate it in a different way. And doing so means that you're starting to look at it from a different perspective. And the more we do that about the problems that are going on in our heads that we're ruminating on or we're blaming ourselves about, the more likely we are to start thinking about it in new ways that may lead to new solutions and helping us to develop awareness of what it is we need.
Right, okay. Well, then this brings us to this one. It's believing things can change and not giving up. So I think most people understand bipolar disorder as this thing that you have, and you have it for life.
Yeah.
And it's just all about sort of coping with it and managing symptoms.
And because a diagnosis of bipolar disorder is usually made by, have you experienced something in the past? What that actually means is that because you can never get rid of that thing that's happened in the past,
Right.
you've always got a diagnosis.
Mm.
So it's almost inherently you can't recover from it, which I think is a bit of a problem. But yeah, it seemed to be this very biological thing. You've got it forever.
Well, expand on that. Like, what are the success rates? What are people's likelihood of recovering from this? And by recovery, I mean sort of it actually becoming a period of the life that's now in the past, and not just something that they're left continuously sort of fighting against or coping with.
Well, the evidence is that these people who have made what they define as recovery do exist. They're out there. There isn't a lot of research on it, though, and I think this sort of enhances this idea that, oh, well, there's no research, so they can't exist. But that's not true. The work just hasn't been done.
Why? Hang on a minute. Why? Because this is, you've got your hall of fame of mental health disorders. And I'd say that bipolar is up there with depression and anxiety as one of the big ones. It's one that everybody knows about to one extent or another. And so why is that there's not much research on the recovery rates of it?
Well, if you don't consider this is something that people can recover from, why are you going to go and do some research asking people about recovery?
Right.
So that's part of the problem. And then also, I think there's some academic censorship that goes on. So, for example, I remember many years ago submitting a paper to a journal with a colleague where we got a letter back from the editor that said, we're not going to publish this or even send it out for review. Why are you even bothering to do psychological research? We know bipolar disorder is due to a problem with the clock gene. That was it. Wouldn't even consider our paper. It took a very long time for all of the research looking at the trauma that people with diagnoses such as bipolar disorder have experienced and how trauma is a huge part of the problems to ever get published. So I do believe that academic censorship still goes on. But a lot of it is, preconceptions about we don't go and do research because we are influenced by what we expect it to be about.
Right.
So there is some research more recently looking at people who have a diagnosis, who have made recovery, but usually it only looked at people who'd been well for around 2 years. So when Helen Warwick and Warren and I did this more recent research, we wanted to look at people who'd experienced a recovery for longer than that. We interviewed about 12 people. The minimum amount of time was 4 years, 6 months, I think, and the maximum amount of time was around 17 years that somebody hadn't had an episode of bipolar that met diagnostic criteria. Now, clearly then, there are people who exist who have recovered from bipolar disorder. And for those of you who might be a bit sceptical and say, but did they really have it in the first place? We did a diagnostic interview in that research. So we checked the criteria that they'd made,
Right.
that they met that criteria in the past, and they did indeed have a diagnosis in the past. But nonetheless, they had made recovery. So it does happen.
Phrasing it like that, though, like it does happen, it's almost like it's inherent in that. Sounds like it's a rare thing that it's
rare that people believe
right
that it can happen. And for lots of people, to be fair, I don't think they do get the help that they need, and I don't think they do reach that point where the things in their life have found some solution to being in balance and, to being able to achieve their life goals. So many people are suffering year upon year and they don't meet recovery.
Right. Okay. Which I'm sort of throwing shit at the walls here and seeing what sticks. This one. So this idea of support, and it sounds quite obvious. Someone's distressed, they're going through a shitty time or whatever, and they're better off with some level of support going on. I'm wondering if there's a particular form of support that's particularly helpful for people with bipolar? And also on the flip side, whether people with bipolar tend to be less supported than maybe other people. You know, maybe it's something that's an actual cause of the distress in the first place, that these people haven't got very supportive networks around them.
Well, I think that's true for anyone with a mental health problem.
Right.
They're often less likely to get support. But particularly people who end up with a diagnosis of bipolar disorder, their behaviour at times is such that other people don't like it. If you're bouncing off the walls because your mood is very high and perhaps you're being socially intrusive, you're over-involved, you're, telling people what they should be doing, you're a bit irritable, others don't like it. And you're more at risk of being isolated and other people not wanting to have anything to do with you.
Right.
Because of the nature in which you might be behaving. So you're less likely to get support, yes.
Right.
But the key thing to come out of our research was what people described as being important for them in terms of support was quite different and varied. Again, demonstrating that what people need and what is helpful, we can't just define it in quite restricted terms. It's a massively individual thing. Different people need different things.
And in terms of, because this is categorised as a serious mental illness, if someone has been given a diagnosis of bipolar, are they more likely to get professional support, like via the NHS? Do we know, like, are they sort of, what's the word, is it expedited, their access to services?
Well, usually people get brought into hospital if they have, become quite manic. So, for example, some of the things that people I've worked with when they've been manic have done is become very aggressive, threatened the police. They may have been naked in public. I remember one person talking about having taken all his clothes off and he was striding down one of the main streets in the centre of Manchester with nothing on. It was raining, through a very busy road at rush hour where all the cars are at a standstill, and frog leaped onto the bonnet of somebody's car.
Jesus,
now that's going to get you into big trouble. Or people are getting into fights, or things that are disruptive and, yes, I agree, quite problematic. So, of course he's going to be brought into hospital, and I think appropriately so, because you're putting yourself and others at risk. But whether or not you end up then getting the help that you need, quite often, unfortunately, and this isn't just my opinion, this is what people tell us, the help that they receive isn't really what they needed and isn't appropriate. It's usually involving just being quite heavily medicated, then discharged when you are in a bit of a stupor and a million miles away from figuring out what it was that wasn't right in your life.
Right. Okay. So here's one. So there's some I'm going to skip over just to sort of briefly mention them. Unless you think they're particularly important. One was instinctive curiosity, so being curious towards your own diagnosis, which, well, now I've mentioned it, it's going to like, oh, go on, what's that about? But I'm less interested in this one. But unless you think it's particularly interesting, just a brief description of why that's an important aspect.
Yep. So again, it's about people starting to question, what is it that isn't right? What is it that I need to make a change to? So a moment ago, I was talking about how often people don't get the help they need from services. And by the way, I don't want to make it sound as though services aren't helpful ever, because if you're brought into hospital because you have been a risk to yourself or others, that is enormously helpful, being taken out of harm's way. But often doesn't allow people to develop awareness of how they want their life to be. What does it mean to live the life you want?
Right.
And so that natural curiosity that people talked about needing to be developed was, what do I need to change about my life? What do I want? Rather than just going through each day saying, oh, I need to manage my mood. I need to try and push and pull my depression. Because when the focus is too much on mood, actually that has a counterproductive effect. the more vigilant you are to, am I depressed or am I becoming high, actually just makes you more anxious.
Right.
What I would recommend people do is say, okay, what is going on when I'm starting to become depressed or when I'm starting to become too high? What is it about that situation that I'm not happy with? What do I need? Rather than just focusing on the mood. The mood is a warning sign. It's like a burglar alarm.
Right.
When mood swings, when your mood's out of kilter and is starting to swing, it tells you that something isn't right. And that's what you need to figure out. That's what that natural curiosity will enable you to do.
Right. Well, I'm glad I didn't skip over that completely then. Then there's becoming the director of your own life, which I think it's going to incorporate into the looking after me section, which is one I want to close up with. Changing how I think. On the face of it, I'm a bit. I don't know. I'm a bit.
Yeah, which is funny you should say that, Danny, because it's always difficult to try and label themes that come out of interviews. And changing what I think sounds very much like something that would fit with cognitive behavior therapy. Yeah. It's like you've got to change the way you think. And that would be a little bit misrepresentative in this case, because what people were really telling us is shifting perspective. It's not necessarily that what you thought was wrong.
Right.
Because I don't believe people have maladaptive, incorrect thoughts. I think every thought is functional and useful. Yep. It's just if it's the only thing you think, it might not be a true and accurate representation of what's going on in your life.
Right.
So it's the ability to think of things from a number of different perspectives, a broadening of perspective rather than saying, oh, I need to change a thought because it's wrong. Does that make sense?
Yes, it does. Yeah, that was sort of my instinctive reaction to it. Is that what we're going for here? Which again, I'm guessing that approach maybe works for some people, but I've just become very skeptical of that whole distorted thinking idea.
I mean, an example is when I'm depressed, it's a terrible thing and I'm never going to be liked by anyone. That is one thought, and actually, that thought may well be very true.
Yeah,
there might be, as I said earlier, a culture in your family for people to be really, walk away and leave you alone when you feel that way.
Yeah.
But if that's the only perspective you have, that might not be helpful. So broadening your perspective is, well, sometimes people might push me away, but if I isolate myself all of the time, then that's going to increase the chances of that happening. Being depressed is also something that keeps me safe because it stops me from, hyping my mood up and going out. So it's understandable that many people who have had horrible periods of being manic, when they're depressed, it might not feel great, but at least they know they're not going to embarrass themselves.
Right.
So there's a whole range of different thoughts that people can have that aren't even necessarily all consistent and compatible about the same mood state.
Right. Okay. And then this one is, so it's accepting who I am and how I feel. Why I'm interested in this one is, on the face of it, it seems that it's maybe could be counterproductive. Accepting the way I am, like, sort of this is just me. It could fall into the reasons to not doing anything about it. Maybe even a rebellious sense, like people are telling me how I should be and how I should behave and how I should feel, and it's like, well, fuck them people. I am who I am. I'm made the way I'm made. I feel the way I feel.
I think it's the limitations of the English language, because when we talk about acceptance, it does conjure up that idea of, oh, leave it alone, just leave it how it is, accept it, make do, put up. Mm-hmm. And again, we had some debate about whether that was a good word to use, but that was the word that many of our participants used, so we stuck with it. But what people were really saying is, far from just putting up with and saying, oh, just leave it and don't do anything about it, they were saying, I need to actually allow certain emotions to be there and realise that they're not necessarily as much of a problem as I think they are.
Right.
So the moment you get a sort of lowering of your mood and you feel a bit fed up, rather than saying, oh my goodness, this is going to lead to disaster, nobody's going to want to be with me, I'm not going to achieve anything, I need to shut myself away, it's actually, does it mean that? Maybe it's okay to feel a little bit low, given what's been going on the past few days.
Yeah.
Maybe I can actually just sit with this and it's not so bad.
Right. And I guess as well, there's for me, there was sort of strength to be gained from acceptance, in the sense of sort of realizing the situation you're in. That I've been given this diagnosis or whatever. I feel the way I feel, and instead of like engaging in self-pity or trying to rail against it, just being like, okay, shit, like this is where we are. I want to deal with this now, and recognizing the situation you're in order to sort of properly prepare and confront it and deal with it.
Yeah. And you're kind of hitting the nail on the head, because the key issue here is, can we get people to a point where they can still go about achieving what's important to them in their life, regardless of how they're feeling?
Right.
And the most common thing I see when working with people is those of the people who think, oh my goodness, I've woken up and I feel depressed. The day's over. I can't get anything done today because of how I feel.
I still do that now, yeah.
And so they're waiting for their mood to change before they go and achieve anything. Mm-hmm. It's a bit of a recipe for disaster. The people who say, okay, yeah, I feel absolutely awful, but come hell or high water, I'm going to get something out of this day, and I'm going to be able to achieve something without regardless of how my mood feels. They're the people who often end up having more of the life that they want.
Yeah, that's very much in line with, so episode 9, Tim Pitchell on procrastination, he phrases that as emotion follows motion. And very often he's talking particularly in procrastination, where you don't feel like doing something. And he says, well, just because you don't feel like it doesn't mean that you can't do
Precisely.
it. So go ahead and do it. And it's very likely that whatever it is you're doing or need to do, once you've got started, you'll get into it afterwards, and then get into the flow of things.
And you might not be able to do it quite in the way that you wanted. And it might not be quite as an enjoyable day as you hoped, but it'll still be a day. Mm-hmm. And that's better than the day being over before you've even got out of bed.
Yeah, totally.
I'm not trying to downplay how difficult that is for people. I'm certainly not saying, come on, get out of bed and you can do it and don't worry about it. I know it is so hard for people to do that. But if you sit and wait for your mood to change, it ain't going to happen.
No, but I can totally appreciate that from the perspective of, dealing with agoraphobia and having kids. It was only, I had my little boy at the time, and just every fibre of my being is just saying, not today. I'm not in the mood today. I'm not going out. I just can't do it. And then you just, that little bit of resolve to just drag yourself out there. And for me as well, sometimes it would happen that the emotion would follow motion. Like I'd go out against my own will, so to speak. And then afterwards I'm like, oh, it's actually not too bad, this. I'm quite enjoying it. But even on the days where it was hell and it was a terrible idea to do it, there was still a sense of reward came, from being the father I wanted to be, and not, ruining my son's day in the process. He wanted to go out and have done it anyway. And also a pride in the rebellion of it. Yeah. And every party is going, don't do this. And you're like, no, fuck yeah, I'm doing it anyway. Yeah. This sort of strength to be drawn from that.
So you've just given a beautiful illustration of the kind of things that people were saying about what brought them to recovery. Because you've just talked about 2 really important life goals for you there. Being the father you want to be, and also actually having some rebellion and beating the process rather than being, the victim to it.
Yeah, totally, yeah.
2 important goals that you were able to achieve. So I would imagine that's an example of you leading more of the life that you want.
Yeah, totally, yeah. Okay, let's close this out now. And this is the concept of looking after me. And there's a few things that were brought up in the paper, but I'm just I'm wondering what you feel are like the most important. And I'm guessing maybe sort of, I don't want to sort of veer into the quick fix self-help thing here, but the things that are sort of immediately actionable, easily accessible things that, again, always trying to think of that audience that are like, look, the therapy sounds great, the medication sounds great, I ain't doing it, I'm doing this myself. There's a lot of those people out there. So, yeah, gearing it more towards those people.
Again, I can't say that there are set things that are quick fixes. It's about, I think the secret here is people figuring out what are the things that work for them. So what our participants in this study were saying is, some people said, oh, I've discovered that I just needed to go for a walk by myself. And they would never have done that when they were just lying in bed. but realizing that that was part of looking after themselves, doing a bit of exercise. Or others discovered actually they loved music, or writing a bit of poetry, or I don't know, going down the pub with their mate. Whatever it is, it doesn't have to even be hugely virtuous. It was figuring out what worked for you. So again, that echoes what's important in terms of life goals for you as an individual. Not doing what somebody expects of you or you think you have to do to be some, valid member of the community, but truly doing what you enjoy.
Right. And I can always with this, people will hear those sort of broader ideas, these broader concepts, instead of Sara Tai saying, go do this now. This works. Go do this. There's a reluctance there. It's like, a broad concept that sounds vague.
Yeah.
How do we get people to overcome that when approaching this? What would you say to someone to overcome that sort of that instinctive need for the quick fix and go, just give me a thinking technique or something I can go out and do for half an hour that's going to fix it, and saying, no, really, you need to sort of, back off from that sort of approach and think about this more broadly.
I often find that the people who want that quick fix and are like, no, I can't, I need it now, are the ones who perhaps are less comfortable with uncertainty. I said earlier, finding the answers here is very much a trial and error process. So my advice would be go out and do something today. Try something, because you might find that you hate it, but at least you know it's not that you need to do. Whereas to put it off, that won't work, or I need somebody to tell me what to do, is a stalling tactic almost of it's going to prevent you from just seeing if something works. Anything you do is different to how you are right now.
Right.
And so you might need to try 20 different things before you find something that perhaps interests you or makes you feel different. It's not necessarily going to solve all your problems immediately, but anything that helps you feel a little bit different and have a broader perspective on things is a step forward.
Yeah. It's one of the things that for me was, did you say just do something, do anything, instead of we've done this sitting in the house every day doing nothing,
but
thinking
it's predictable.
About it. Yeah, it's predictable, ruminating, and it's gone on for years and it's not fixed anything. So just do something, do anything.
And we are uncertain as to whether that will work, and try and tolerate that uncertainty. If it doesn't work, you're no worse off, but you've done something.
Yeah. And let me also preface the do something, do anything within reason, because but seriously, the do anything approach for me is what led me to sort of experimenting with my own chemical fixes, alcohol, codeine, things like that. Do you know what I mean? And it was like,
when I say do anything,
yes.
I mean definitely within reason, nothing that's going to harm yourself or someone else. And when I say harm yourself, I don't just mean physically or mentally. I mean that's going to take you further away from those important life goals.
Right, yeah.
Because if one goal might be to feel better, and taking a bucket load of illicit drugs tonight may well do that tonight, but it will take you further away from some of those other goals that you hold, maybe of, just in your own example, of being a good father, of being the father you want, being able to even do what you're doing now, like interview people. It's not going to help you achieve that, is it?
Right.
So it's how well does your quick fix or the thing that you're going to try doing differently fit with the other things that are important to you in your life?
Okay. So plenty for people to sort of chew on there, and hopefully a little less emails coming in now from people going, great bipolar episode. Now what do I do? So that hopefully this episode will serve as a bit of a guideline for people on that. But before I let you go, quick fire questions. Okay. About 5 or 10 minutes this might take, depending. And the reason I'm sort of particularly interested in inflicting this on you is anyone that doesn't know Sara will be we'd have to let you off for that, because you can go Google you and you barely exist on the internet. In trying to do a bit of research on you for this, I've found one interview, which was just on a blog with Eric Maisel, I think it is. And then there was a little 5-minute one that you did with the mental health podcast as well. So you're sort of reluctant with the whole media thing.
Oh, yes.
Why is that?
I don't really know. I suppose I'm quite self-conscious and I don't like the sound of my own voice often. And it's all those silly little things that we all get into of fear of negative judgment, fear that I will have nothing intelligent to say or I'll sound stupid. So yes, I tend to veer away from doing media. But it's funny because as you asked me that question, I started to do what I've been advising people to do as we've been talking, and that's think about what it says about what's important to you in your life. And it's very important for me to try and appear successful, which would mean maybe doing more interviews. But at the same time, I really loathe the idea of coming across as conceited and everybody listen to me and I've got something to say and blah, blah, blah. So I think I often shy away because I'm quite fearful that people will think, no, here she goes again. And
Right. Well, so you're going to be confronting a couple of those fears directly with this now. Because
conflicting goals, don't I?
Let's see how this goes. So about 10 questions. Starting with, what's the best book you've ever read and why?
Oh, I absolutely loved Wild Swans.
Okay, never even heard of that one.
And bizarrely, the name of the author just has totally escaped me. I can't believe I can't remember her name. It's okay. Terrible.
It'll be in the show notes, everyone, as usual.
So it's actually a book about China. And I read it a long time ago. And obviously my name, Tai, I have Chinese ancestry.
Right.
And my grandfather came from China. And just reading that book was such a great insight to the Cultural Revolution that happened in China and lots of things that might have been experienced by that side of my family. And I just found it fascinating because it was a mixture of history, of culture, of learning about people, but most of all, the human side of people, because that's what fascinates me.
Right. If you could take the reins of power at the Department of Health, what policy would you implement to improve the mental well-being of the general public?
Well, I would most definitely change policy on giving people more autonomy. Because I'm totally about people being able to make their own choices. And I can't bear the idea of people being diagnosed and then given set treatments and being told what they need to do. It goes against all of my ethos. And let's give people the autonomy to make their own decisions where they're able to.
Right, here we go. This is where we start getting deep now. I think that those two are easy territory. Favourite book and mental health policy. And you're not obliged if you like. Some and plenty of people do go like, "Oh, I can't answer that one." Let's start with this one. What negative experience has had the most positive effect on your life?
Oh, that could be a rather personal one. So, yes, no, I have had some pretty adverse experiences in life, and not ones I often talk about. So,
well, it doesn't have to be. It's sort of implied in that question. Yeah, what's the worst? It doesn't have to be the worst, but just it's.
I don't mind being open. I'll go for it. So, so I've had some pretty difficult experiences. In terms of, as a student, experiencing extreme poverty was one that I remember, many years ago. That was very difficult. So I'm certainly not suggesting that I understand how other people with very adverse social experiences feel, but I certainly know how it felt for me. And learning a lot about life, of how to sort of pick yourself up from that. But the other thing, I suppose my main negative experience in life is, I'll be honest, I have some fairly chronic physical health problems. And I do believe that trying to work around those is in a similar vein to what I've been saying in relation to mental health. So there are some days where, you feel so unwell, it's really hard to get out of bed. And, you'd have every reason for staying in bed, but I know the day would feel pretty lousy. And there are times when I drag myself out of bed and will get through the day regardless. And it's not quite the day I envisaged or would have chosen, but it's a day.
Yeah.
And I say that's really taught me a lot about just carrying on. Just keep going. Even if you only achieve a quarter of a step that day, it's a quarter of a step.
Yeah.
And just be grateful for it. I hope that doesn't sound too, nicey.
No, it's
because the reality of it is it's, some days are rubbish, but it's still a day.
Yeah, that's it. I totally agree. Just it's like I say, the big thing for me, just not giving into it. Just even if you, like you just said, then if you just do a little bit of something, it's better than nothing. So
and you have to deal with not quite being the person that you wanted to be that day, and that's tough.
Yeah.
But it's life.
What's the best piece of life advice anyone's ever given you? And if nothing quickly springs to mind, an alternative is what quote resonates with you the most?
There's a little theme here of I am so rubbish at remembering names. I don't know who said it, but somebody once said that other people, they won't remember what you say. They won't even remember what you do. What they'll remember is how you made them feel.
Yes, it's in there somewhere. I know who said that.
I don't know who said it. I really can't remember.
It is a good quote.
But I love that. And the reason that resonates with me is because it requires you to think about how your actions might be impacting on, somebody else, but not from your perspective. It means I've really got to understand what's going on for this person from their perspective.
Yeah, it's like the golden rule, isn't it?
Yeah, absolutely.
Yeah.
So also Bill Powers, who obviously is the author, that he sort of conjured up perceptual control theory, talked about that. Don't do unto others as you would like others to do unto you. Do unto others as they would like others to do unto them.
Yes.
And it fits.
Yeah.
And that for me is like the most important quote.
Okay. What mistakes do you continue to make despite knowing better?
Oh, many.
What springs to mind?
I always sort of make the mistake of assuming that other people are thinking bad things about me.
Right.
When the answer is, who cares? Just do what you're going to do anyway. And who knows, Danny, I might even do more radio interviews after this or more interviews doing something. But at the end of the day, don't even go there in terms of tuning into those negative thoughts. Focus on what it is that maybe is important to you, and to hell with what other people think. Right. I continue to make that mistake. I allow that, they might think negatively, to block me from maybe doing what I should be doing.
What is a harsh truth you choose to ignore, but know you shouldn't?
About anything or about myself?
Anything.
Well, a harsh truth is I'm just not perfect, and I'm never going to be.
Well, that's one we all have to face up to, isn't it?
Yep.
This sometimes conjures up an interesting answer. What do you know to be true that everybody else thinks is bollocks?
That I'm always right.
That stands in contradiction to what you were saying before. But I'm wondering if there's truth in that, to the extent that you're confident about your knowledge of things and your place as a professor, as a researcher. You're confident in the work you do and the way you apply it, but the problem comes when it's putting it out there. Is that the case?
Yes, it's about. Well, it's funny because, believe it or not, I actually used to do a lot of theatre work, which meant being on stage.
Right.
Now, you might think that's just such a bizarre thing to do, given that she doesn't like, talking. And when doing sort of amateur dramatics and things, you're playing at being somebody else. So when I'm talking about a theory or some work that maybe I didn't do. I don't have a problem with that. The difficulty for me comes from when it's me,
Right.
when I'm exposed, or when I'm putting my own ideas out there academically. You know, it's the fear of criticism or fear of not being right.
Right. Well, I've got to say, Sara, that is the most confident answer I've ever had to that question. What do you know to be true that most other people think is bollocks? That I'm always right. So, congratulations.
No, but actually, that's what I would like to think. But we all live in perpetual conflict. And so there's a part of me that does believe I'm always right. But then there's that other part that believes that that's total rubbish and believes what other people think. And that's bollocks.
It doesn't actually. It's you're assuming that other people think it's bollocks as well, rather than it actually
precisely.
being the case that they do.
Well, that's because I also think it's bollocks and that I am not always right. So, and that's my point. We never hold one belief. We always have the opposite of that as well. So,
okay, final three. What, if anything, keeps you up at night?
Oh, I am somebody who just can't get enough hours out of the day. There's always something else to be done. And because I'm a little bit perhaps of a perfectionist, it's got to be done right. That keeps me up at night. I'm a busybody.
Outside of family and career, what investment of time or money has brought you the most joy or fulfillment?
Outside of family and
career. They're the two easy go-to ones.
Well, I don't think we're talking about single purchases here. So the fact that I once bought an umbrella for a large sum of money, which is the most expensive thing I'd ever bought in my life, sort of gave me enjoyment because it was a bit frivolous. But
no. Let's not, hang on a minute. I need to know about this umbrella now. And in fact, again, I think you've done a first there of actually talking about a singular purchase. So how much are we talking for an umbrella?
Well, it was £75 for an umbrella, and it was quite a while ago, a number of years ago. So that was quite a lot of money. And the reason it brought me so much joy, well, apart from it was an exquisite umbrella, it truly was. But it was, I'm not somebody who ever spends money on myself.
Right.
And so there was something about just saying, maybe on this occasion you're worth having this object just because you simply think it's exquisite. That felt quite important.
Yeah, it doesn't necessarily have to be a shallow purchase.
No, it wasn't. Oh, I bought an umbrella because I wanted it.
Yeah.
It was the first time in my life that I said, right, I'm going to purchase something for me. It was when I'd actually finished my training, so it was like it was a reward, almost. But even that, the reward wasn't the issue. It was saying you're worth it.
Yeah, no, that's a great answer. Okay, the final one, the big one. Mm-hmm. What do you think is the key to happiness?
Well, I'm in danger of giving an answer that sort of is in line with the theory, like
go for
living your goals, doing what you want and living the life you want. But the key to true happiness is just that having that self-awareness again, of not just being in the moment, like all this mindfulness stuff tells you to do, because being in the moment just goes with accepting. It's about stepping back from the moment, not accepting it and saying, what does it tell me about what I need and who I am?
Dr. Sara Tai, thank you very much for joining me.
Thank you, Danny. It's been an absolute pleasure. And I hope everyone has a lovely day.
There you go, you did it. A full hour and 20 minutes.